Hello, everyone. Welcome to Surviving Sepsis 2021 updates for the management of sepsis and septic shock. Today, we are pleased to have the following panelists: Dr. Anna Maria Crawford, Dr. Francois, Dr. Karima, Dr. Fred, Dr. Vanessa, and Dr. Rediet. Before we begin, we would like to start off with a few housekeeping notes. So we will be using the chat function for question and answer today. If you have a question, please send them through the chat box and feel free to introduce yourself. If you have any IT or technological issues, also please feel free to send us a message through the chat. Today's session is being recorded and your attendance is consent to be recorded. Thank you. And please be mindful of infection prevention and control. Try to limit the number of people joining from one gathering place and practice physical distancing. And with that, I'll hand it over to our lead presenter today, Dr. Anna Maria Crawford.
Thank you, Alana, and thank you all for joining us. We're really excited to share with you the updates for Surviving Sepsis campaign. I'm going to share my screen so we can get started. So the information that we're going to display today is on the Global Anesthesia and Critical Care Learning Resource Center. For those of you who have not signed up for a free account on the LRC, we'll put the link in the chat box so that you can sign up for that. And then you can view everything that we show you today. There's lots of free links and lots of free resources here. So you can see this is on the left, our course, Critical and Intensive Care Medicine, and there's lots of different learning modules within this course. And so we're here in module 7, it's called Sepsis and Septic Shock. So I'm gonna minimize this navigation pane here. Also just wanna point out that when you're on the Learning Resource Center and you're within a learning module, anytime you see this small paper clip here in the right upper hand corner, that means that there are materials available that are free to you to download. The two materials that we have for you today is the Surviving Sepsis campaign article that contains all 93 updates that we'll be discussing today and Friday. As well, there's facilitator PowerPoint slides so that if you want to, after going through this lecture with us, you want to use these slides, you can go and teach about sepsis and septic shock using those slides. So today we're going to talk about part 1 of sepsis, septic shock, and the guidelines for treatment for adult patients. In October last month of 2021, the European Society of Intensive Care Medicine and the Society of Critical Care Medicine published updated international guidelines for the management of adults with sepsis and septic shock. The full guidelines can be found here and here. So if one of the good things about the Learning Resource Center is if you click on many things, you get access to several different articles. So you can see if we click there, we actually get a link to the article that we're going to be discussing today and Friday. They publish this in 2 different places, so we have 2 different links. It's just 2 separate journal publications. So you can get this article 2 different times through the links. And then again, if you click on the paperclip icon, you can get it there. Unfortunately, a lot of you asked when you sent in your preliminary questions about managing sepsis and septic shock in pediatric patients. These guidelines that were just released last month do not address pediatric care. However, we do have another link here that will take you to sepsis management guidelines for pediatric patients. So we tried to get you the information that you needed. Unfortunately, we won't have time to talk about pediatric sepsis in these sessions. Similarly, many people asked about peripartum sepsis, and we gave you 2 links here that you can feel free to access and read in your own time. So again, this is a 2-part session. There's 93 updates to the sepsis guidelines, so we had to break this up into 2 sessions. Part 1 is screening and early treatment, initial resuscitation, mean arterial pressure, admission to intensive care, infection, source control, and hemodynamic management. We have 2 hours today. We're going to try to get through all of these topics today. And then on Friday, we'll do part 2, where we talk about ventilation, additional therapies, long-term outcomes, and goals of care. So with that, I want to start us off with our case presentation. And Dr. Mean, would you mind reading the case presentation for us? Good morning and welcome. I think you're on mute.
Yeah, good morning.
Good morning.
Yes, happy to be here with you. Our case is presuming you're working in a rural district hospital and the nearest hospital with an ICU is 20 miles away. The physician working in the emergency room calls you to come see a patient that she wants to admit to the hospital. The history of the present illness is that Mr. G is a 66-year-old man with 3 days of diffuse abdominal pain and blood-tinged diarrhea. He occasionally has nausea, but no emesis. He reports feeling weak, and he has stopped eating and has not gone to work for 2 days. He is mostly lying in bed. The vital signs on presentation include a respiratory rate of 29, heart rate of 108, blood pressure of 103/59, temperature 37.5, and he has a saturation on room air of 91%. And the initial response is that Mr. G is placed on 3 liters of oxygen therapy by nasal prongs, and his pulse oximetry readings improved to 95%.
Great, thank you so much. So this is the case we'll be discussing throughout today's session as well as Friday's session. So the first section we mentioned was screening and early treatment. We have some objectives. We like to talk about learning transfer that leads to practice change. So our objectives is not just learning this material, but actually changing our practice so that we take better care of our patients. So for screening and early treatment, we want to be able to define sepsis and septic shock. We want to institute screening and identify it early. We want to understand and utilize appropriate clinical scoring systems, recognize sepsis and septic shock as medical emergencies, understand mortality rates in sepsis and septic shock, understand the value and limitations of using lactate during resuscitation, and list the 5 steps in the Hour 1 bundle for sepsis and septic shock, and understand how to implement them in your setting. So a lot of us practice in a lot of different settings with different resources available to us. So that's why we have panelists from all over the globe in different practice settings so that we can discuss novel solutions for implementation, even if we have resource constraints. I'm going to go ahead and just read the very first recommendation from the guidelines. And it basically states that for hospitals and health systems that we use performance improvement programs for sepsis and septic shock. So we need to screen for these patients and understand the standard operating procedures to get treatment to these patients. So no discussion there. We need to be looking for sepsis. Every hospital needs to be evaluating their own performance around taking care of sepsis and septic shock. So our first question is, what is sepsis and what is septic shock? Throughout this series today and on Friday, we are going to ask questions. We encourage everyone, all of our participants, to try to answer the questions. And in order to answer, put your answers in the chat box if there's no poll that's generated. If there's a poll generated, then use that to answer the question. So what is sepsis and what is septic shock? So put your answers in the chat box. What is the definition of sepsis and what is the definition of septic shock? Okay, I think everyone's still warming up to the idea, but we want our learners, oh, good, here comes Maria Cristina, gracias. Sepsis, generalized infection through the bloodstream. Sepsis is a systemic response to infection. Great, people are starting to put in their answers in the chat box. Wonderful. So sepsis was actually defined in 2016 by the Sepsis 3 group. And they came to a third international consensus for the definition of sepsis and septic shock. So again, on the Learning Resource Center, you can actually click on this article title and it will take you directly to the article, okay? So the good thing about the Learning Resource Center is we have curated all of these resources for you. So if you want to read the entire article, you can just click there and it'll take you directly to the article. Instead of doing that, thank you for all those great answers in the chat box. That's wonderful. I'd like to ask Dr. Vanessa Mall, do you mind reading these 3 points within the definition of sepsis and septic shock?
Absolutely.
Thank you.
The first one, sepsis should be defined as a life-threatening organ dysfunction caused by a dysregulated host response to an infection. Second, septic shock should be defined, it's a subset basically of sepsis, should be defined as a subset of sepsis in which particularly profound circulatory, cellular, and metabolic abnormalities are associated with a greater risk of mortality than with sepsis alone. Patients with septic shock can be clinically identified by a vasopressor requirement to maintain a mean arterial pressure of 65 millimeters of mercury or greater, and a serum lactate level greater than 2 millimole per liter, which is more than 18 milligrams per deciliter, in the absence of hypovolemia. So this is after you have resuscitated your patient.
Perfect. Thank you so much. So in short, it's a life-threatening organ dysfunction, dysregulated response to infection. So the next question, in order to appropriately treat critical illness, we must first recognize when patients are critically ill. How does your hospital or clinic identify critically ill patients? So I'm going to give you just probably 30 to 45 seconds. What does your hospital do to identify critically ill patients? How do you know someone is critically ill? So Alexi says they use news. I don't think he's watching the news. I think he's using a clinical scoring system called news. Vital signs, great. Drop in vital signs. Well, drop maybe, but also could be elevated. Another person uses news. Physical assessment, vital signs, labs. Wonderful. Okay, these ill looking, so just physical exam and observation. Wonderful. So these are all great answers. I'm going to click on the box for the answer, and what we actually would encourage learners to learn about. And it comes from this article, again, open access and free. It's called Vital Signs Directed Therapy, Improving Care in an Intensive Care Unit in Low-Income Countries. And instead of going through the entire article, I'm going to go to this first figure, and I'm going to ask my colleague Karima if she wouldn't mind taking us through this chart, this Vital Signs Directed Therapy Protocol.
Absolutely, Anna. So the Vital Signs Directed Therapy Protocol is a protocol that has been developed to take us through any critically ill patient, and we consider septic patients to be critically ill patients. And we always go with the usual ABC. As we approach any critically ill patients, we assess the airway and we look for any derangements in the airway. As you see in this table, we have the normal ranges, which are shown in green, and the deranged vitals in yellow, and the ones which are in danger sign are shown in red. So, for example, when you look at the airway, we consider the conscious level of the patient. So normally the patient who is awake and conscious, has a Glasgow Coma score of 15. But once this score goes down to around 9 to 14, then we consider it abnormal. And if it's below 8, then we see that this patient is critical now. So what we need to do, and also when you look at the airway sounds, are they normal? Are we hearing normal airway sounds, or are there any abnormalities in the airway? Like, for example, are we hearing some gargling sound, snoring, or a stridor? So we have to, once we see these kind of problems in the airway, then we take action. And these actions are basic actions that can be taken by any person working clinically in a health facility. So we need to protect the airway so the patient doesn't aspirate and cause further problems. Things like lateral positioning of the patient, chin lift, jaw thrust, or the use of an airway adjunct like an oropharyngeal airway will be helpful in opening the airway and protecting the airway somehow. And then we look at the breathing of the patient. Are they breathing normally? And the breathing rate is normally between 12 to 18. And it's the range, it's abnormal if we have a range of 8 to 11 or 19 to 30. And the patient is in danger if the respiratory rate is more than 30 or less than 8. So we also consider their oxygenation. Do they need oxygen more than 10 liters? Less than 10 liters per minute, or if that means there's an abnormality, and if it's more than 10 liters, that means that patient, or more than 80 to 100%, that means that patient is in danger. And the last thing that we look into the breathing, also we have to look, which is very crucial, is their saturation, oxygen saturation. And if the normal range that we take is around 95 to 100, but if it's below, it's between 90 to 94, that means it is abnormal, and if it's less than 90, that means they're in danger. So how do we intervene in that case? So we think this patient could be hypoxic. They are actually hypoxic. And we could do multiple maneuvers, sometimes like sitting the patient up or increasing oxygenation. If they're not on oxygen, put them on oxygen, like the patient that we have seen in our case, where the saturation was around 91, and they were put on oxygen, it went up to 95. So you increase the oxygenation of the patient and see the response. And in each step that you take, you reassess the patient and see if there's improvement and if there's any further change that you need to take. And the other part that we look at is the circulation. And the first thing that in circulation that we have to look at is the heart rate. And we all know that normal heart rate is around 60 to 100. And if it's above 101 to 110, then that means that the patient is having a tachycardia. And if it's more than 130, that means the patient is in danger. And if we have a heart rate around 40 to 59, that is also an abnormality. And if it's less than 40, that means also the patient is in danger. So what do we do? That means that the patient is in shock. And we can do several maneuvers like tip the patient's head downwards, and give them IV fluids, like we'll see in the sepsis protocol, like giving them 30 liters per kilo of their weight to resuscitate the patients. We also look at when you're looking at circulation, you also look at the systolic blood pressure. If it's around 100 to 180, that is we consider it okay. And if it's less than 90, if it's around 99, that is abnormal. And if it's less than 90, then that means it's the patient might be in danger. And also, if it's more than 180, that means the patient is hypertensive, and so what we are going to deal with more is the hypotension in this part. And this, if they're hypotensive, then that means we have to resuscitate the patients. So always we have to remember that for every intervention that we make to the patient, we have to recheck their vitals again and assess if they are still in danger or if there is if the treatment is working. And always ask for help from a senior personnel if the response is not good, and even if it's good and you need further assistance, then you need to ask for senior assistant to intervene. Thank you so much, Anna.
Wonderful. That was such a great summary. Appreciate it.
Thank you.
Okay. So we'll go back to the case. And I think it's good to know that we did the right thing for Mr. G by putting him on oxygen when his saturation was 91%. So I think the biggest takeaway is really to not only to start looking for septic and septic patients, to recognize when people are critically ill and make sure that you activate the system that's needed to treat them. And that might just be calling a senior doctor. Let's see, Rediot, would you mind to read this next question for us, please? And it looks like we have a poll that pops up with this one, which is great. So I'm just going to ask the panelists to not answer the poll because it will actually stop the poll if I'm remembering correctly. So just the learners, not the co-hosts.
Okay. Which one of the following is no longer recommended as a single screening tool for sepsis and septic shock? A, QSOFA, B, Muse, C, SEERS, D, Muse.
Okay, so learners, you can answer in the chat box, but we also have launched a poll for you to use. Try to answer in the poll that popped up on your screen if you can. I think it's almost evenly split between SERS and quick SOFA, which is interesting. But we'll go ahead, we can close that poll. I think everybody's going back and forth between C and D, or A and C rather. Okay. So the official recommendation, that's interesting. So the official recommendation is that we not use quick SOFA compared to SERS, NEWS, or Muse as a single screening tool for sepsis or septic shock, which is interesting because in 2016, when the Surviving Sepsis campaign launched their guidelines, they actually used the quick SOFA as part of almost part of the definition and recognition of sepsis. So the reason they're saying not to use it now is that although a positive QSOFA should alert the clinician to the possibility of sepsis in all resource settings, it's poorly sensitive. So the panel issued actually strong recommendations against its use as a single screening tool. So it doesn't mean you can't use it. It just means you have to take into consideration other things that might be going on with the patient. So I'm going to ask this next question, and that is, how do you calculate QSOFA or quick SOFA, NEWS, Muse, and SERS? How do you calculate these things? So if people are a little bit slower to answer, I actually would be slower to answer as well because I'd have to get out, I'd have to get out my resource to do that. So if you online softwares, that's a perfect answer, actually. Thank you, Abir. So if you click on the question, it actually takes you to an open access free resource that's called MD Calc. And I use this resource all the time. It has lots of different equations and calculations for a lot of things that we do in medicine. So you can calculate anything from a CHAD score to a BMI. So if you just type in QSOFA and then select it, it'll give you a calculator. And so you can plug in whether the patient has altered mental status, their respiratory rate, or systolic blood pressure. Similarly, if you wanted to calculate a NEWS, you can again just select from these menus. I'm just making up numbers, and it'll tell you what the score is. So you get 9 points, and then it tells you what the score means. So we won't go through all of these. I just want you to know that MD Calc is free. It's online, open access, and you can use it. You can also download it as an app on your phone. So I find it very useful. I think maybe you might as well. Okay, so what are your first steps in managing Mr. G? So in the chat box, what are you going to do to manage Mr. G? We put him on oxygen. Is there anything else we need to do? So we'll go back to the front of the case. He's had some diarrhea. He doesn't feel well. He might have had some fever. Now his respiratory rate is 29. His heart rate is 108. Blood pressure is 103/59. Temperature is actually 37.5, so no fever currently. And now his oxygen saturation is 95% on 3 liters by nasal prongs. So people are saying IV access, great. Abir's learning quickly, ABC, vital signs directed therapy. Collect samples for lab. IV fluids from Jose Carlos. Hydration. Great. Okay. So I think the first thing is to recognize that this patient possibly has sepsis, and to act quickly. Sepsis and septic shock are life-threatening emergencies. So you need to minimize the time to treatment, monitor closely, and communicate the status when you hand off the patients to others. Right, great answers in the chat box. So we said that this is a medical emergency. So with that, I wanted just to quickly review the incidence and mortality of sepsis across the globe. This data is from 1990 to 2017, and you can see that across the globe, there's different colors overlaid on different countries. And the darker the color, the greater the incidence of sepsis and mortality related to sepsis. So you can see across much of the globe, we still have a lot of work to do. So Southeast Asia, Africa, Central and South America, and even some of the other countries still have a ways to go in the north as well. So it is definitely, the mortality associated with sepsis and septic shock has decreased over time, but that hasn't been experienced in every country across the globe. Okay, can I ask Dr. Meem again to read the next question, please?
So what diagnostics and laboratory investigations will you obtain in this patient?
So a lot of you said you're going to start an IV and send some blood samples. So what types of diagnostics will you get on this patient? A full blood count, great. What else? We say in North America, we actually say a complete blood count, which is, we call it a CBC, but in a lot of places we call it a full blood count or FBC. ABG, great. If you have access to arterial blood gases, I think that's a reasonable thing. Blood cultures, great. Septic workup is not very specific unless you have an order panel. Procalcitonin, okay, we'll definitely talk about that. Blood cultures, urinalysis and a chest x-ray, great. Chem 7, also called a survey 7 or a basic metabolic. Wonderful, these are great answers. Okay, I'm gonna ask Dr. Meem to continue with this question and go through the 1 hour bundle, if you don't mind. So this is a bundle for an initial resuscitation for sepsis and septic shock as recommended by the Surviving Sepsis campaign.
Yes, so I think what immediately becomes obvious here is the numbering system here. These numbers are put in a specific order to emphasize the priorities given to what should be done first and what should be done second and after that. And you can see that with the initial recommendations there, as far as laboratory testing, is the value placed on lactate levels. And we have more to say about that, but lactate over 2 is considered abnormal. And again, there's more to be said about an elevated lactate, about whether that's only a sign of poor perfusion or not. But then number 2, most importantly, is to get blood cultures to rule out septicemia. In other words, the systemic spread of an infection, no matter where it started. Is it actually systemic now? Does the patient have bacteremia or septicemia? And getting those cultures before number 3, the administration of antibiotics, also kind of a key order of priorities here. If you give the antibiotics first, you may inhibit or diminish your chances of actually culturing the actual organism that started this infectious process off. And then number 4 is the resuscitation, fluid resuscitation of a patient with recommended 30 milliliters per kilogram. This is to give you a clear idea of the volume of fluid necessary in people who have septic shock, what kind of volume they need. That doesn't mean that every single patient always gets 30, but you need to use your clinical judgment. It's a good starting point if you have no restrictions on fluid. And then if that kind of initial fluid resuscitation isn't adequate, it doesn't mean that there isn't ongoing fluid resuscitation needed after this 30 milliliters per kilogram. But if it's not immediately effective, then we're going to use vasopressors, number 5, to restore blood pressure to a targeted mean of 65 millimeters mercury.
Excellent. Thanks so much, Dr. Main. Yeah, I think you made a great point in that even though you do number 4, which is begin the rapid administration of 30 milliliters per kilogram crystalloid, that you don't stop there, that you continuously reassess your patient to see if they are volume responsive. So we'll talk a little bit more about that, but recognizing that this is a medical emergency and that it's time sensitive or time critical, I think is one of the big points with this. You know, we talk about critical care, and this is, I know Dr. Karima will have opinions about this, but we talk about critical care, and oftentimes people will think of ICU, but critical care happens anywhere, and it just means that it's time sensitive or time critical, and so we need to intervene quickly. So we suggest, so that's one of the labs we'll send. Okay, is Dr. Francois with us? I can't see the participant list.
Yes, I'm here.
Oh, good morning. No, good afternoon. How are you?
Yes, good afternoon, and how are you?
Good to hear your voice. Do you mind reading the case update for us?
Of course not. So, as past medical history, Ms. J, for past surgical history, no previous surgeries, and for he's married, retired, 3 other children, does not smoke or use alcohol. So for physical exam, he's awake and alert with non-focal neural exam. For GCS, he's 15, regular heart rhythm, but tachycardic. Breath sound are clear bilaterally. Abdomen is soft but slightly tender to palpation, especially in the lower quadrant. No rebound or guarding. Liver edge is not left. Extremities are cold. Capillary fill time is 30 seconds. No edema. The height is 181 centimeter. Weight is 75 kilogram. The emergency MD start an 18 gauge peripheral IV to start a crystalloid infusion, lactic acid, full blood count, and complete metabolic panel, transaminase and a coagulation panel has been drawn and sent to the lab. A portable chest X-ray was also ordered, but is pending.
Morkozicane. So the fourth recommendation is that sepsis and septic shock are medical emergencies, and we recommend that treatment and resuscitation begin immediately. So we're doing the right thing for Mr. G. He's on some oxygen for his hypoxemia. We've got an IV started for crystalloids. We've sent some labs. We've sent for an X-ray. So that actually concludes the first section. And now we're going to move on to initial resuscitation. Dr. Mull, do you mind walking us through what our practice change will be after learning these, the materials in this section? Vanessa.
Oops, hold on. So I had to unmute myself.
No problem.
Always
I can't see your face when I'm screen sharing, so apologies if I just
no problem. So the initial resuscitation, we will calculate the initial fluid bolus that should be given to any patient with sepsis or septic shock. And we just learned that it's 30 mils per kg. Choose the appropriate fluid for volume resuscitation. So should we be using balanced crystalloids? Should we be using colloids? Should we be using normal saline? We'll talk about that. Understand the complications associated with inappropriate fluid choice. List 4 examples of dynamic measurements for fluid responsiveness. So think PPV or the passive lag race test, for example, or an echo and ultrasound. List 1 dynamic measurement of fluid responsiveness that is universally available. Recite the ideal capillary refill time and test capillary refill time on yourself.
Great. Thank you. Dr. Francoise, can you read the next question for us, please? And I think we may have a poll for this one. So we want the audience to answer on the poll for this next question.
Sure. So Ms. G weight 75 kg. How much crystalloid fluid should be given to Ms. G during initial resuscitation?
Wow, wonderful. Everyone is answering, almost everyone is answering correctly, both in the chat box and on the poll. Wonderful. So much like we said, we don't want you just to be able to recite that it's 30 milliliters per kilogram. We want you to change your practice, and that involves actually doing the calculation and ordering the crystalloid fluids. And the correct answer is D, 2,250 milliliters. Perfect. For patients with sepsis, this is the 5th recommendation from the article. For patients with sepsis-induced hypoperfusion or septic shock, we suggest at least 30 milliliters per kilogram of IV crystalloid fluid should be given within the first 3 hours of resuscitation. And as Dr. Meem mentioned previously, that's where we start. We have to continuously reassess if the patient needs more fluids at a later time. Dr. Vanessa, you alluded to this next question, so I think I'll let you take this one.
Excellent. According to the Surviving Sepsis campaign in 2021 updates, which of the following is an acceptable and recommended fluid for resuscitation? Is it A, gelatin synthetic colloid solution, B, normal saline, C, albumin, or D, hydroxyethyl starch?
Okay, let's see your answers to this. Which one is acceptable?
And you can see we actually have 3 colloids and just 1 crystalloid on here.
Look at those answers coming in. This was kind of a tricky question, I think.
Yeah, I totally think it's a very tricky question.
It's a very tricky question. I'm proud of myself for making a trick question. Okay. So I think most people are answering in the chat box, but here come the polls. Almost everybody's saying B, which is normal saline. Okay. Vanessa, do you want to tell us what the trick was? by reading these are direct quotes. These next quotes are direct quotes from the Surviving Sepsis Campaign Updates articles.
Yes, I'm happy to. This was an excellent question, Anna.
Thanks. I'm proud of it.
In the face of inconclusive effect of mortality, increased adverse effects, and higher costs, the panel issued a weak recommendation against the use of gelatin for acute resuscitation. More high-quality studies are needed to inform future guideline updates.
Okay, so A is incorrect. A is incorrect. Okay.
A is incorrect.
Let's read the next one.
Now we go to B, and I think this is the kicker for everybody, because we are so used to just hanging the normal saline solution, and have been for the past, I don't know, probably
ask Fred.
Yeah,
He's
exactly.
Been longer than
how long?
How long have we been using normal saline, Fred?
Why would I know that question?
Because you've been practicing longer than the rest of us, sir.
Oh yeah, that's right. Yes, I have been. Yes, we've been using it for many decades, and I think the evidence now suggests that's inappropriate.
Yeah.
Yeah. So I can tell you, I've been practicing medicine for 20 years, and I've been using it for 20 years. So for longer than that. Okay, I'll read the quote now. For decades, the administration of normal saline solution, which is 0.9% of sodium chloride, has been common practice, but potential adverse effects that include hyperchloremic metabolic acidosis, renal vasoconstriction, increased cytokine secretion, and concern about AKI, which is acute kidney injury, led to increased interest in chloride restrictive solutions, known as balanced or buffered solutions. So that would be a plasma-lite or even a Ringer's lactate. Subsequently, a network meta-analysis of 14 RCTs, randomized controlled trials of patients with sepsis, comparing all these crystalloids, showed an indirect comparison that balanced crystalloids were associated with decreased mortality compared to saline. So using balanced solutions led to a better patient outcome. So no more saline, nay to saline, yay to balanced solutions.
Okay, what about albumin? That was actually the answer. Okay, so if we come back to the question, gelatin's out, saline's out, and now we have albumin and hydroxyethyl starch. So what about albumin?
The suggestion to consider albumin in patients who received large volumes of crystalloids is informed by the evidence showing that higher blood pressure at early and later time points, higher static filling pressures, and a lower net fluid balance with albumin. Limited data precludes a cutoff value for crystalloid infusion above which albumin might be considered as part of resuscitation.
Great. So that's actually our answer.
Exactly. Albumin is actually good. So how I have been doing it, I'm starting with crystalloids, and then I would switch over to albumin. And then we're talking about hydroxyethyl starches. And here the statement is, in 2016, the sepsis guidelines, a strong recommendation was issued against using hydroxyethyl starch. And no new data was identified here, but no to hydroxyethyl starches.
Yeah, so this is clearly a learning point and an opportunity for us all to change our practice when caring for sepsis and septic shock patients. And in the chat box, Lakshmi made a great point that balanced salt solution wasn't one of the answers. And that's correct. It wasn't part of the answers. And this is how I tricked you. I put saline in there and albumin in there. And historically, we've been using saline, but not as much albumin. So this is a bit of a switch with the recommendations. So you would start with a balanced salt solution and then consider albumin. So kind of a big change with the guidelines. So now we'll read the guidelines themselves. So everything in these blue boxes, the recommendations are pulled exactly from the article. So for adults with sepsis or septic shock, we recommend using crystalloids as first line for resuscitation. We suggest using balanced salt solutions. Alana, for some reason, the poll keeps popping up and I can't get rid of it. I'm not sure how to take that out. Sorry. We suggest using balanced solutions instead of normal saline for resuscitation. So this is a big switch. We suggest using albumin in patients who receive large volumes of crystalloids over using crystalloids alone. So they're actually encouraging us to use crystalloids first, use balanced salt solutions, and then we can add in albumin if needed. We recommend against using starches for resuscitation, and we suggest against using gelatin for resuscitation. Those are old, those haven't changed. We haven't been using those things. I find it interesting in our culture here in the US, I feel like anesthesiologists for years have been saying to use balanced salt solutions such as lactated ringers, Plasmolite, Normasol, but some other training backgrounds prefer saline. So I feel like
Anna, can I make another point?
Please do.
That is that one of the historical reasons why saline has been used in resuscitation is that it's the recommended, in the past, it was the recommended fluid to give if you were giving blood to a patient, that there were recommendations not to use lactated ringers. And now that we have Plasmolite or Normasol, what we call Normasol, the same solution, those Plasmolite or Normasol can be given with blood. So there's no reason to use saline, even if you know you're giving blood with your resuscitation.
And can you take us back another step further, Fred, and explain to us why it was contraindicated or recommended against using lactate while you're giving blood?
Well,
it's the calcium and citrate interaction, isn't it?
Yeah, they're worried about the calcium in the lactated ringers.
Yeah.
Normasol has no calcium, has magnesium instead of calcium. And so Normasol or Plasmolite can be given with blood.
Great. Thank you so much. Redia, do you mind reading this next question and taking us through?
Not at all.
Thank you.
Thank you. Which one of the following is considered a dynamic measure of responsiveness to resuscitation? A, stroke volume and stroke volume variation. B, passive leg raise. C, pulse pressure variation. D, echocardiography. And E, all of the above. So you can respond in the chat box.
So that looks good. What do you think about those results, Redia? I think only 53%, according to the poll, and now some people answered in the chat, but according to the poll, 53% said all of the above. But we still have another 50%, 47% that picked only one of the others. So we can go through the recommendations here, if you don't mind, Redia. 6, 7, and 8. She might be having a connection problem. So I'll just read them for us. For adults with sepsis or septic shock, we suggest using dynamic measures to guide fluid resuscitation over physical exam or static parameters alone. Dynamic parameters include response to passive leg raise or a fluid bolus, using stroke volume variation, pulse pressure variation, or echocardiography where available. So Dr. Mull, you mentioned this in the beginning when you were reading the learning objectives. Some of these things are available in some resource settings and some of them aren't. Which ones do you use in your practice?
So in my practice, I actually like to use the passive leg raise test when I can, because I think it exemplifies a response to fluid when you don't have to give fluid. So basically what you do is you lay your patient more or less flat, maybe 15% head up, and then you raise the legs to about 45 degrees, and that gives you an internal, I guess, blood bolus back from the legs to the central compartment of about 500 cc's. And then you just watch your blood pressure response to that, or even your heart rate response to that. And if this patient responds to the volume with an increase in blood pressure, then you know that this patient is fluid responsive. And of course, you cannot do that in every patient. There might be surgical things complicating this, or you have in the high resource settings infraballoon pumps in the groin, so you cannot do this. Then I would be doing either stroke volume variation or PPV, or even have an echo probe in my head and just pop my ultrasound onto a patient's heart to assess. But I think the first thing to do that I like to do is the passive leg raise test, because it's just so easily and readily available pretty much everywhere.
Yeah, I would say, assuming your patients have legs, it's available. So yes. I think that would be a good one for most of us to use, because not all of us have access to the echocardiography or stroke volume assessments. So number 7 is we suggest guiding resuscitation to decrease serum lactate with elevated lactate levels over not using serum lactate. During resuscitation, serum lactate level should be interpreted considering the clinical context and other causes of elevated lactate. So Dr. Meem touched on this a little bit earlier, but if you have access to serum lactate, they are recommending that you check it within that 1 hour bundle, and then use that value as the baseline and resuscitate your patient so that the serum lactate goes down. Dr. Meem, did you have something else you wanted to say about the clinical context and other causes of elevated lactate?
I think we'd love to make things simple, and in medicine, things aren't always so simple. And lactate levels, if it's elevated, a general assumption is that's a sign of poor perfusion and a shock state. And it certainly may be, but also remember that the majority of lactate gets converted by the liver into pyruvate, and if the liver is damaged in some way, or the primary organ that's dysfunctional, then it may not clear lactate very well. And so the problem with an elevated lactate may be just a matter of lack of clearance of lactate rather than production of lactate from a shock state. So there's no easy way around that to sort that out, unless you have a laboratory to measure pyruvate levels. Yeah. And that's a very specialized lab that most major hospitals in the US do not have.
We don't process.
So don't have that information, but you do have to just consider that. Is the liver injured or not? Do I have a situation where that applies?
Thank you. So the last recommendation, number 8 in this box, we suggest using capillary refill time to guide resuscitation as an adjunct to other measures of perfusion. So capillary refill time should be 2 seconds or less. So I'm just going to ask the audience to take a minute to look at your own fingers and calculate your capillary refill time and put it in the chat box. So everybody look at their fingers and count, squeeze the finger until the blood is gone and release, and count how many seconds it takes for the color to return to your nail bed. So everyone's saying 1 to 2 seconds. It can change if you're cold and if you're dehydrated, but they are suggesting that we look at the capillary. Dr. Amos, I'm so sorry, 4 seconds. You need to go drink some water, I think. Okay, great. Dr. Amos, I'm a little concerned. You're the only one with 4 seconds, so I think we should get you something to drink. Okay. Dr. Karima, we're going to move on. Thank you guys for doing that. That's how we change practice, is by not just thinking about it, but doing it. So now we all have measured capillary refill time. So you can do that in your patients when you're concerned about perfusion. Dr. Karima, do you mind reading this next case update, please?
All right, sure. So right now, Mr. G has received 2,250 mils of IV crystalloid over 2 hours. Blood cultures, urine culture, and sputum cultures have been ordered. And the labs came with a lactate level of 4.5 millimoles per liter, white blood cells at 17, and serum creatinine at 230 micromoles per liter. His vital signs are currently a respiratory rate of 28, a heart rate of 115 beats per minute, a blood pressure of 99/46, and temperature of 38.5 degrees Celsius. His saturation, oxygen saturation is 94% on 3 liters per minute by nasal prongs.
Okay, so in summary, he has an elevated lactate, he has an elevated white blood cell count, he has an elevated serum creatinine, an elevated respiratory rate, an elevated heart rate, and he has a fever, and he's requiring oxygen. So Mr. G has probably defined himself as sepsis in almost all of the clinical scoring systems we use. But we mentioned that there's a difference between sepsis and septic shock. So what is the next most appropriate intervention and therapy to improve the outcome for Mr. G? So what would you do next for this patient? You've given him oxygen, you've sent his labs, you've given him fluids. So he's already received the 30 milliliters per kilogram. Okay, some people want to give more oxygen, but most people, an antipyretic. Thank you, Kim Hing. Vasopressors is the most common response. And so why did we decide that he needs vasopressors? So we're going to move on to our next section, and that's mean arterial pressure. Rediat, are you with us again? Can you perhaps read these next objectives? Or Karima, I think Rediat might be having difficulties. Do you mind continuing?
All right.
Thank
so
you. Okay.
Our learning transfer. Oh, she's back. You go ahead.
Good.
I'm back. Sorry about the interruption.
No problem.
So mean arterial pressure. So the objectives are to calculate mean arterial pressure when given systolic and diastolic blood pressure values, and to recite the goal for mean arterial pressure during hemodynamic support during septic shock.
Okay, wonderful. So I'm going to remind you, his blood pressure is 99 systolic over diastolic of 46. What is Mr. G's mean arterial pressure? So 99 over 46. Danny has the right answer. So if everyone can look at Danny's answer in the chat box. And Nail. Perfect. So if you're like me and you like to use calculators, again, you can click on the question or download the app onto your phone and go back to MD Calc, and you can just type it in here. And it'll give you the answer. Oh, sorry, it was 46, not 64. Apologies. So 64 is his mean arterial pressure, which is less than our goal. I do want you to know, everyone should know, especially the anesthesia residency trainees at the University of Rwanda, you should pay attention. The mean arterial pressure is 1/3 systolic plus 2/3 diastolic. Okay, so that's how you can calculate it in your head. Okay, so his mean arterial pressure is now 64. Okay, Rediat, do you want to ask this next question as well?
Assuming he has been adequately volume resuscitated, will you start Mr. G on a vasopressor agent? A, yes. B, no. So it's a poll.
Yeah, it's a poll. I think many of us already answered this prior, but
yeah.
So it's mostly yes, but still a little bit of a debate. And so I think this is actually common, and I think it's reflective of what happens clinically as well. And the question is to give more fluids or to start pressors. So that's kind of the debate I think that people have with themselves when they're caring for septic shock. And so I would just take us back, and this is really good guidance from the experts in sepsis and septic shock, in that if you have given IV fluids to the point that your patient is no longer fluid responsive, capillary refill is 2 seconds, passive leg raise doesn't increase the blood pressure, that means your patient is volume resuscitated. So if they're still hypotensive at that point, then yes, the answer is A. We do need to start vasopressors if their MAP is less than 65. Do any of the other panelists have anything to add to that? Because I think this is very common for us to get confused. Should we give more fluids or should we start pressors?
Yeah, I would just add that if, as I mentioned earlier, it's initial resuscitation, yes, but there may be ongoing resuscitation. I think some clinicians make the mistake of giving a certain amount of fluid, and then as soon as they start vasopressors, they stop with any idea about giving additional fluid resuscitation because they're in the vasopressor mode now. And I think there are many conditions like pancreatitis or sepsis where the initial resuscitation was good, but they have ongoing needs for ongoing fluid resuscitation as well while you're giving pressors to help support the blood pressure.
Yeah, I think that's an excellent point. I don't know if the learners have ever heard the expression, don't squeeze an empty tank, but you can actually get into more trouble if you continue to go up and up and up on your pressors without giving fluids. And then similarly, if you don't start vasopressors and you continue to give too many fluids without the vasopressors, then you can also get into complications with pulmonary edema, et cetera. So great, thank you, Fred. Okay, how about Karima? Do you mind reading this one, please?
All right. Which one of the following values is the most appropriate blood pressure goal for most patients in septic shock requiring vasopressor agents? A, systolic blood pressure of more than 100 millimeters of mercury, and B, mean arterial pressure of more than 60 millimeters of mercury.
To target the MAP and to target a MAP of greater than 65 millimeters of mercury. So great. The answer is D, MAP greater than 65. So here's the recommendation from the guidelines for adults with septic shock. On vasopressors, we recommend the initial target of 65 millimeters of mercury and over. So they don't want you to target higher MAPs either. So this recommendation is really about overshooting. Some people try to target higher blood pressure thinking it will improve the outcomes, and that's not correct. So we're going to move on and talk about admission to intensive care. And this is very relevant to our discussion in that Mr. G is in a district hospital without an intensive care unit. And so this recommendation is going to cause some challenges for us when we're working in rural areas. So we need to list the goal time frame in which patients with sepsis or septic shock should be transferred to an ICU, and list at least 5 considerations when transferring critically ill patients. And this can apply to inter-hospital, which means between 2 facilities, or intra-hospital, which means within the 1 facility. So for adults with sepsis or septic shock who require ICU admission, we suggest admitting these patients to ICU within 6 hours. So if you're working in a district hospital and you have access to an intensive care unit at a hospital nearby, 6 hours is not a lot of time. So we really need to be thinking about arranging for that transport sooner rather than later. So I want all of the learners to think about what resources Mr. G is most likely to need during his illness. And I mean during his entire hospital course, not just right now. What is he going to need? How do you anticipate his clinical course progressing? And list some of the resources that we're not giving to him now that he will need. So if you can list some things in the chat box, what you think Mr. G will need to get better and recover from his sepsis. And then we'll talk about how to arrange transfer to ICU for this patient. So first, what do you think Mr. G will need during his hospital stay? Good. So I kind of started us off, and now people are starting to think about. So Mr. G is critically ill. We identified that by diagnosing him with sepsis and now septic shock. So patients that are critically ill need a lot of resources, labs, x-rays. He may or may not need surgical consultation, which means he needs anesthesia and an OR, pathology, urine output monitoring. He might need a blood transfusion at some point, antibiotics, fluids, oxygen, antibiotics. He might need a central line, ventilator. Very good. Great. So the nutrition, wonderful. Thank you, Protejan. Physio, wonderful answers. I can tell you're going to do ICU. All of those resources may not be available and likely are not available in our rural or district hospitals. So we really need to transfer the patient as soon as possible, if possible. How do you arrange transfer for a patient from a district hospital to a hospital with an ICU? What are the considerations for arranging transfer? How do you do that logistically? What are the steps? Good, Sarah. DVT prophylaxis, great. Stress ulcer prophylaxis, wonderful. Okay, I'm going to click on this box because if I know myself, I gave you a resource that talks about transferring ICU patients. And so let's see if I found something good for you. This is a checklist for critical care transfers. I'm not suggesting this is the only checklist out there, but I think it is good to categorize the resources and be systematic about how you approach transferring critically ill patients, because critically ill patients are at very high risk of complications and decompensation. So the first thing in this checklist says preparation. Is the patient fit for transfer? As a provider, as a physician, you have to decide, is it safer to transfer the patient and get them a higher level of care, or is it too unsafe to transfer the patient? You need to make sure there's qualified and trained medical personnel that can accompany the patient. You want to make sure the patient has been accepted at the receiving facility and that they have the consultants and critical care consultants that are needed. You want to make sure that all of the medical information is provided, so the case notes and investigations. You want to make sure you inform the family. And then you want to make sure that the ambulance is contacted, there's appropriate personnel in the ambulance, that they have oxygen, the monitors, and everything that are needed. And so then you actually can use this checklist to go through the airway, circulation, breathing, and then any other disabilities or monitoring that may be needed during the transfer. And you want to make sure everything that the patient may need is in place so that it's safe. And then right before you leave, you want to do a timeout for the transfer. So staff has introductions, the patient's stable, airway equipment is available, oxygen and batteries. Running out of oxygen in an ambulance is not a good idea. IV access, infusions, sedatives, vasopressors, inotropes, fluids, all of these things will be needed. Blankets is very important if you're in a cold place, or especially if you're doing an air evacuation of a patient. So all of these things are good. And this checklist I found, and I think it's a nice starting point. It obviously would need to be, and here's the website that you can send comments to. But I think it's a nice place to start, and it might be good for you to adapt it to your own setting. Okay, how about Dr. Francoise, do you mind reading this case update? Please.
Sure, thank you. Case update, remember your settings. You are working in a rural district hospital. The nearest hospital with an ICU is 20 miles away. Mr. Jean has been at your hospital for 3.5 hours. Know your local resources. Point 2, know how to triage patient within your facility. Know how to stabilize the patient prior to transfer. Identify and prepare for the risk of transferring the patient. Know how to implement smooth and safe transfer of a patient to a higher level of care. Safety first. Practice good preparation and communication with transferring team.
Thank you. So this is actually outside the scope of the guidelines that have been published by the Surviving Sepsis campaign. This is something that I wanted just to include with the checklist, just to help you understand how to have safe transfer of critically ill patients. So it's really a separate discussion, but a very important one in my opinion. So next we're going to move on to the section about infection, and there's a lot of good information here regarding antimicrobials. We want to be able to recite the time frame in which antibiotics should be given to a patient who is suspected of having sepsis or septic shock. We started to discuss that in the hour 1 bundle when we talked about giving antibiotics within that first hour, but also considering obtaining blood cultures. Understand when antibiotics should not be given. List the appropriate use of procalcitonin to guide management. Someone already mentioned procalcitonin earlier. List at least 4 risk factors for infection for MRSA. MRSA is methicillin-resistant Staph aureus. List at least 4 risk factors for infection with MDR, or multi-drug resistant organisms. So we say MDR or we say MDRO, multi-drug resistant organisms. And those are just the bugs that are resistant to our antibiotics. List at least 4 factors for infection with fungal organisms. And then write an order for prolonged or continuous infusion of beta-lactam antibiotics. So I'm going to make you do another activity so that you not only learn, but you change your practice. Okay, so we're going to just read the 11th recommendation in the guidelines. For adults with suspected sepsis or septic shock, but unconfirmed infection, we recommend continuously reevaluating and searching for alternate diagnoses and discontinuing antimicrobials if an alternative cause of illness is demonstrated or strongly suspected. Simply said, if there's no infection, stop the antibiotics. So back to the audience, would you give Mr. G antibiotics? Yes or no? You can answer in the chat. Or the poll. Almost everyone is saying yes. I agree. I would give him antibiotics as well. Okay, we have another case update. I'm going to move us along a little quickly. We're already running out of time, I think, considering we have 45 of these to get through. So Vanessa, do you mind reading this next case update, please?
Absolutely. Mr. G received IV fluids with crystalloid solution, initially 30 mils per kg, followed by an additional 500 mils until his cap refill time decreased to less than 2 seconds. He was started on noradrenaline at 10 micrograms per minute to maintain his mean arterial pressure of higher than 65 millimeters of mercury. The emergency room physician has also ordered a CT of his chest, abdomen, and pelvis to look for the source of his presumed infection.
Okay, do you mind continuing?
Of course.
Thanks.
You asked the emergency room physician to administer antibiotics to Mr. G, but she states that she is waiting for the procalcitonin results from the lab. How do you respond?
How would you respond to this, audience? You ask the emergency room to give antibiotics and they say, we are going to wait for procalcitonin. Is that correct or incorrect, and why? Thank you, Karina. Percio, Freddie, hi Freddie. Jean, Justin, perfect. Great. Okay, Vanessa, what does the recommendation say from the Surviving Sepsis campaign about procalcitonin?
Yes, so the audience was correct. With no apparent benefit, unknown costs, and limited availability in some settings, including LMICs, the panel issued a weak recommendation against using procalcitonin to guide antimicrobial initiation in addition to clinical evaluation. So basically, the benefit of giving antibiotics early supersedes procalcitonin, and it's not really readily available, and so you don't want to wait. It's better to start early and then de-escalate early if antibiotics become unnecessary or are unnecessary.
That's
so
right.
The recommendation then would be for adults with suspected sepsis or septic shock, we suggest against using procalcitonin plus clinical evaluation to decide when to start antimicrobials as compared to clinical evaluation alone. Weak recommendation and low quality of evidence.
Perfect. And I think our learners agree. Is Mr. G at risk for MRSA infection? Yes or no? And I'd like you to answer in the poll or the chat box, please. Wow, okay, interesting. An overwhelming number of you are saying he's at risk for MRSA. I actually disagree. So let us click on the question box and see what our resources say. Up to Date is a very commonly used resource where they review the literature and come up with recommendations. It does require a subscription, you can see here, but this table was free. So some of their materials are free and open access. If you don't already have a subscription to Up to Date, they do offer discounted or free rates for LMICs. So the risk factors for MRSA include recent hospitalization, residence in a long-term care facility, recent surgery, hemodialysis patients, HIV, injection drug use, prior antibiotic use, Factors associated with outbreaks include prisons or incarceration, military, sharing sports equipment, sharing needles, razors, or other sharp objects. So I'm going to go back to the question. Do you think that Mr. G is at risk for MRSA? Would you change your answer? He's not at risk. He didn't meet any of those criteria for MRSA. This is very important because when we have patients with MRSA, the most commonly used antibiotic that we start for that is vancomycin. And vancomycin can have untoward effects on the kidneys. So if you don't meet the criteria for MRSA infection, you don't have to get extra antibiotic coverage for that. So the recommendations for adults with sepsis or septic shock at high risk of methicillin-resistant Staph aureus, we do recommend using empiric antimicrobials with MRSA coverage over not using MRSA coverage. However, we suggest against that as if the patient doesn't meet those criteria for MRSA risks. So that's a big learning point too. So we've had, I think, at least 3 questions where the answers were incorrect because it was based on old evidence. So these are good changes to recognize in your practice. So will you give vancomycin automatically to a septic shock patient? Probably not. You'll probably evaluate to see if they're at risk for MRSA. Great. Karima, do you mind reading this next portion?
Sure.
Thank you.
So now the symptoms of Mr. G, now he has diarrhea, weakness, anorexia, and abdominal tenderness. He feels tired and states that his abdominal pain is worsening and is mostly localized to the lower quadrants. His signs are that he has a fever, tachycardia, tachypnea, hypotension, and hypoxia. Diagnostics that have been run showed a lactate that is elevated. The white blood cell count is also elevated. Serum creatinine is elevated. His chest X-ray is clear, but with small lung volumes. CT, chest, abdomen, and pelvis is still pending because of the machine is broken. Interventions that were done, Mr. G now has improved blood pressure with a MAP of more than 65 millimeters of mercury after IV fluids, and with a noradrenaline infusion. His SpO2 is stable at 95-97% on oxygen by nasal prongs, set at 3 liters per minute. He has now received 2 grams of ceftriaxone. On assessment, septic shock, presumed abdominal source of infection, and the plan is to transfer to a higher level of care as soon as possible. And his update is that the nearest hospital with an ICU has accepted the patient for transfer. The patient and his family agree to the transfer. The insurance includes coverage for ambulance services. The ambulance will arrive in 15 minutes to pick Mr. G up and transport him to the tertiary hospital.
Perfect. Thank you so much. Do you mind reading the next question as well?
Is Mr. G at risk of multi-drug resistance MDR organisms? A, yes, and B, no.
Okay, you're on, audience. Tell us what you think about MDROs. Yes or no? Lakshmi says no. Kim Hing, no. Okay, so we still have a bit of a split, don't we, Karima? Some say yes, some say no.
Absolutely, we have a lot of no's compared to yeses, but of course in the chat box also we have a lot of splits. Yeah.
Okay, let's see what the risk factors are for MDROs. Okay, antimicrobial therapy in the preceding 90 days, hospitalization of 5 days or more, high frequency of antibiotic resistance in the community or the specific hospital, presence of risk factors for hospital or healthcare associated pneumonia, hospitalization for 2 days or more in the preceding 90 days, nursing home or extended care facility, home infusion, including antibiotics, dialysis, home wound care, family member, or immunosuppressive disease. I would say if you look at this table, he doesn't meet any of those requirements. So I would say the answer would be no. So that means that we don't have to use certain antibiotics. We just need a broad spectrum antibiotic, but we don't need two different ones. So Vanessa, do you mind reading these next three recommendations, please?
Of course. For adults with sepsis or septic shock and high risk from multi-drug resistant organisms, we suggest using 2 antimicrobials with gram-negative coverage for empiric treatment over 1 gram-negative agent. So here they suggest 2 versus 1. For adults with sepsis or septic shock and low risk for MDR organisms, we suggest against using 2 gram-negative agents for empiric treatment compared with 1 gram-negative agent. So here, low risk, you use 1, high risk, you use 2 gram-negative coverage and antibiotics. For adults with sepsis or septic shock, we suggest against using double gram-negative coverage once the causative pathogen and the susceptibilities are known.
Great. So because he's low risk, we would just use 1 antibiotic. And then especially once we knew our sensitivities, we could tailor the antibiotic to that specific organism. Rediat, do you mind asking this next question and going through the 2 recommendations that follow?
Okay. Is Mr. G at risk for fungal organisms? A, yes, and B, no. So you can respond in the chat box.
I think people are tending to use the poll more now that they understand it, which is great. What do you think, Rediat, of those answers?
Yeah, many people are saying no.
Yeah.
Yeah.
Which I agree with. So let's look at the risk factors for fungal organisms. Again, you just click on that question box and I put a resource behind it so you can look. And this actually comes straight out of the articles that we're covering. So this is within the Surviving Sepsis guidelines. And it talks about risk factors for Candida, so neutropenia, immunosuppression, TPN, perforations, GI surgeries, renal failure, dialysis, risk factors for yeast, and risk factors for mold. So many of these are just immunosuppressed patients for different reasons. And I would say that Mr. G is just coming in from home. He's not been in the hospital. He's not a dialysis patient. He's not been on previous antibiotics that we know of recently. So I would consider him low risk for fungal infection. What do you think, Rediat?
Yeah, I agree with you, Anna, completely.
Do you want to read the recommendations 22 and 23 for us?
Okay.
Actually, we'll do 24 as well.
Okay. For adults with sepsis or septic shock at high risk of fungal infection, we suggest using empiric antifungal therapy over no antifungal therapy. And 23, for adults with sepsis or septic shock at low risk of fungal infection, we suggest against using any form of antifungal therapy. So if there's no risk, there's no need to give antifungal therapy.
Great.
And we make no recommendation on the use of antiviral agents as well here.
So I think it's interesting throughout the article. There's lots of discussion of evidence and a lot of recommendations, but in the middle of a viral pandemic, they didn't make any recommendation of antiviral agents. And do you mind just reading the quote from the article? It kind of explains why they made no statement.
Okay. Viral infections encompass a broad spectrum of pathogens and diseases in humans, but apart from specific clinical situations such as epidemics or pandemics, are rarely the primary cause of sepsis. In a recent large international point prevalence study, viruses were documented in less than 4% of infections. And due to the rapidly changing position related to antiviral therapies in critically ill patients presenting with several acute respiratory failure This panel decided not to issue a recommendation on antiviral therapies and to refer the reader to more specific guidelines.
Thank you. This says several acute respiratory failure, which I think is supposed to say severe acute respiratory failure, which I think is interesting because this is a quote. So I actually copied it from the article and pasted it here. So it's actually a typo in the article itself, which is interesting. Okay. Recommendation 25, for adults with sepsis or septic shock, we suggest using prolonged infusions of beta-lactams for maintenance after an initial bolus over conventional bolus infusion. This is a change even for my practice, in that if you, for example, prescribe meropenem, it's written, you know, for example, 1 gram every 8 hours, you would give a bolus every 8 hours of the 1 gram of meropenem. But what they're saying is when you're using beta-lactam antibiotics, that it actually, the infusion shouldn't be, usually that bolus is given in 30 minutes or less. And instead of bolusing beta-lactam antibiotics, we should be running them in over a prolonged infusion or a continuous infusion. So I actually am going to skip to the recommendation or the quote here, and then I'm going to ask you the question. So beta-lactam antibiotics may be subject to changes in important pharmacokinetic parameters in the setting of sepsis and septic shock, resulting in subtherapeutic concentrations. As opposed to conventional intermittent infusion, administration by prolonged IV infusion, either as an extended infusion or as a continuous infusion, results in sustained beta-lactam concentrations, which align with the pharmacodynamics of these drugs. So instead of writing meropenem 1 gram Q8 as a bolus, you would need to write meropenem 1 gram Q8 infused over 8 hours if you want to do continuous, or infused over at least half of the dosing interval. The dosing interval is 8 hours. You would infuse it at least over 4 hours, or you can infuse it over the entire 8 hours. That way the patient's receiving that beta-lactam antibiotic continuously, or the prolonged, definition of prolonged is to run it over at least half of the dosing interval. So we have an example here. Instead of meropenem, Mr. G has received 2 grams of ceftriaxone as his initial antibiotic therapy. So that was the initial bolus. The dosing interval is every 24 hours. How can you write the order for a prolonged infusion? So take a chance and put it in the chat box. How would you write the order in the chart for ceftriaxone 2 grams? Every 24 hours if you want it to be a prolonged or continuous infusion? You have to be specific in your order. Great, Jean. Great, Blessing. Matthew. Yeah, so most of you have chosen to do the prolonged infusion, which is half of the dosing interval. So you would infuse it over 12 hours. If you wanted to do continuous infusion, you would just write it over 24 hours, or just write continuous. Yeah, so over 12 hours is the prolonged infusion. Great. So for adults, we recommend, with sepsis or septic shock, we recommend optimizing dosing strategies of antimicrobials based on accepted pharmacokinetic and pharmacodynamic principles and specific drug properties. If many of you are like me, you don't have all of the pharmacokinetic and pharmacodynamic principles of specific drugs memorized, and you would have to look this up. What this statement I interpret as meaning is that we really need to involve our pharmacy colleagues for consultation on a lot of these medications to make sure that we are dosing them correctly. I don't know if any of the other panelists took a different meaning from this, but either look up the information as you write the prescriptions or engage your pharmacy colleagues to help you.
Yeah, and I think there's in a lot of settings, there are no critical care pharmacists around. So I think that just puts a bit more responsibility on oneself to have little, handbooks available, or to look it up on your smartphone to get your resources, make your resources available so that you can actually take charge and look it up before you order.
Yeah, I think the easy part about that, Vanessa, is that most of us have a limited menu of medications that are available at each hospital. So it somehow makes it easier because we only have to look up the properties for those medications.
Exactly.
Obviously, the larger the menu, the more work you have to do.
Yeah.
We're going to move on to source control. I'm going to ask Dr. Meem, would you mind reading the objectives for source control?
Sure. The source control issues are understanding the methods and timing of source control, appropriately manage intravascular access device in patients with sepsis and septic shock, prescribe appropriate durations for antimicrobial agents, understand when to de-escalate antimicrobial therapies, and understanding the role of procalcitonin in the discontinuation of antibiotics.
There's that procalcitonin again. So we're going to talk more about that. Great. Do you want to continue with the case update, Fred? Do you mind?
Sure. Yep. Mr. G has been transferred to the tertiary center by ambulance. He remained stable during transport on nasal cannula and a low-dose noradrenaline infusion. He is now admitted to the ICU. He's on continuous monitoring, including pulse oximetry. He remains alert and awake, but his abdominal pain is worsening, and he has now had 2 episodes of emesis. He's on IV fluids, and he's received ceftriaxone 2 grams. His vital signs updated now are a respiratory rate of 29, heart rate of 118, blood pressure of 99/42, temperature of 38.5, and a pulse oximetry reading of 93% on 3 liters of nasal prongs, 3 liters of oxygen by nasal prongs. Diagnostics include a CT chest, abdomen, and pelvis without contrast, which was performed. The chest part of this exam shows clear lung fields with decreased lung volumes, bibasilar atelectasis, and smaller trace pleural effusions, and no pericardial effusion. The liver appears to be normal. The gallbladder is slightly enlarged with sludge, but no wall thickening or gallstones seen. The spleen looks normal. The pancreas and adrenals and kidneys all look unremarkable. And then the GI tract shows multiple mildly distended small bowel loops containing air fluid levels within the mid to distal small bowel. There is gradual tapering distally to the level of the terminal ileum with no definite transition point identified. Air fluid levels throughout the colon are suggestive of diarrheal illness. There's a colonic wall thickening in the left lower quadrant without emphysema or surrounding inflammatory changes. No findings concerning for abscess. A normal appendix is identified in the right lower quadrant. The bladder is unremarkable. The abdominal aorta is normal in caliber with scattered atherosclerotic calcifications, and the bone and soft tissues are unremarkable.
What is your interpretation of his imaging?
Well, there's often an awful lot said about something that doesn't mean a lot, and then
I wonder who wrote this case.
The job is to zero in on what's really where's the money here. Yeah, where's the important piece? And it sure looks like it's his gastrointestinal tract. There's some problems, And of course, that matches with his gastrointestinal symptoms. So there's air fluid levels in his small bowel, some tapering. We don't see a transition point suggestive of some ischemic bowel perhaps, or an obstruction, a point of obstruction, but there's still a concern of that. So I think these findings are suggestive of perhaps some kind of intestinal inflammation, but he doesn't have appendicitis, and he doesn't have evidence of a perforation, which would be the more urgent things that would indicate surgery is needed. Yeah.
Karina has actually suggested a few bacteria that might be at fault here. So we'll see how it goes. So the recommendation for adults with sepsis and septic shock to rapidly identify or exclude specific anatomical diagnoses of infection that require emergent source control and implementing any required source control intervention as soon as medically and logistically practical. I think this is a fancy way of saying, does your patient need surgical intervention to remove a source of infection? So how do you get control of the infectious source for Mr. G? Any ideas? Okay, well, let's keep moving. We'll think about that and come back to it. We recommend prompt removal of IV access devices that are a possible source of sepsis or septic shock after other vascular access has been established. Does Mr. G have a vascular access device that we can remove? He doesn't, does he? If we had put in a central line, would we take it out? Do you want to comment on that, Dr. Meem? I know you have a lot of experience with these lines.
Well, we've just started taking care of this patient. So any of the lines we put in, whether they're a peripheral IV or a central line or art line, none of these things would be suspect as a nidus of infection or source of infection.
Right, his infection was there prior to the insertion of the device, isn't it?
Exactly. If he came with existing IVs or an old central line, of course, yes.
Yeah. A couple people in the comments have said to call for surgical evaluation or review. So Jean definitely asked for that, and then Karina went as far as to say to call the surgeon for a possible laparoscopic exploration and get the results from stool cultures, which are things to consider as well. I think a lot of times exploratory laparotomy is utilized, but if you have good diagnostics such as a CT, then it's not necessary to go in and explore unless there's a definitive source that can be removed. So the case update is that a surgeon was consulted. He says there's no indication for surgery and recommends bowel rest and resuscitation for hypovolemia. So sometimes surgeons do too much and sometimes they do too little. Apologies to any surgeons in the audience. The laboratory calls and says the blood cultures say gram-negative bacilli. Urine culture is pending, but the urinalysis was unremarkable, and the respiratory culture is also pending. So now we have some direction in which to go with our treatment, and that we have gram-negative bacilli, okay? Okay, let me get ready. Do you mind to read 29 and 30 recommendations from the article?
Okay. For adults with sepsis or septic shock, we suggest daily assessment for de-escalation of antimicrobials over using fixed durations of therapy without daily reassessment for de-escalation. For adults with initial diagnosis of sepsis or septic shock and adequate source control, we suggest using shorter over longer duration of antimicrobial therapy.
Wonderful. So we're not going to do surgery. We have him on antibiotics. We know we have a gram-negative bacillus. So we need to make sure we get speciation and sensitivities, and then we can actually tailor our antibiotic choice to that specific bug instead of just using broad spectrum. Great. Karina, you're right. Assuming his hospital course improves over the next few days, for how long would you keep Mr. G on antibiotics, assuming he gets better? How many days? Most people think 5 to 7 days is what a lot of people are saying, that they feel comfortable. Some people saying 10. Oh, I love that. Discontinue. I wouldn't discontinue yet because we actually have a bacterium in our blood culture. So the patient is bacteremic, possible abdominal source, right? So let's look here. For adults with an initial diagnosis of sepsis or septic shock and adequate source control where optimal duration of therapy is unclear, we suggest using procalcitonin and clinical evaluation to decide when to discontinue antimicrobials over clinical evaluation alone. And of course, I didn't leave you without information. If you click on the question box, it will take you to a resource that happens to be the Surviving Sepsis campaign that we're actually discussing. And they give you planned duration of empirical antimicrobial therapy for different sources of infection, shorter versus longer duration of therapy according to clinical syndrome. So they reviewed all of these articles and showed duration, shorter duration versus longer duration for example, pneumonia. And you have the shorter duration defined as anywhere from 5 to 8 days versus longer, which is 10 to 15 days. And it showed there are no difference. One suggests that even 3 days of treatment was adequate. Bacteremia, which is what our patient has right now, is 5 to 10 days. 7 to 14 days, or 8 to 15 days for an intra-abdominal infection. And then this one, UTI, says 5 to 10 days. You go back to the recommendation, they're going to say shorter duration. And then they also say use procalcitonin. So if your patient has clinically improved and you've covered the shorter duration of antibiotics and you've seen a decrease in your procalcitonin, you can actually stop the antibiotics. I do board review questions for my maintenance of certification in anesthesia and critical care, and I had this question literally yesterday. So they're already putting it into our board review questions. But if your procalcitonin has gone down, the patient's clinically better, you can actually stop antibiotics, which is a big change for a lot of these recommendations. Okay, Karina, can I go back to you for the beginning of hemodynamic management and talk about the learning objectives there, or practice change objectives, as I like to say?
All right, so practice change objectives are hemodynamic management. Name the first line vasopressor agent for septic shock. List 2 alternative vasopressor agents that are recommended if the first line agent is not available, and list vasopressor agents associated with higher incidence of dysrhythmias. Describe when vasopressin should be used, and list 3 agents that can be used for septic shock with cardiac dysfunction.
Perfect. Thank you so much. Do you mind reading the next question?
Sure. Which of the following vasoactive agents is least likely to precipitate dysrhythmias? So is it A, vasopressin, B, dopamine, C, epinephrine, and D, levosimendan?
So
and then the poll running.
Yeah, the poll's running. The other way to ask this question is, which of these agents are associated with dysrhythmias? And that would be all the wrong answers. Oh, this is a good question. There seems to be some confusion here. Lots of different answers, isn't it?
Yeah. and they seem to be going hand equally.
Priscilla, I'm going to go back to, sorry, I'm going to take a second to go to Priscilla. If we're not able to get procalcitonin, how long is reasonable to administer antibiotics? Go back to the table that I showed you, Priscilla. So if you go back up here and click on this box and it gives you that table, which is also within the article that I gave you 3 ways to download, then you can use this information here for whichever sort of infection your patient has, whether it's pneumonia, bacteremia, intra-abdominal, or UTI. Choose one of the shorter durations, and as long as your patient is clinically improving, you can stop the antibiotics after that many days. If your patient's not improving, you should probably continue the antibiotics. Okay, so back to the vasopressor question and which ones are associated with dysrhythmias and which ones are not. I'm going to ask Vanessa. Vanessa, can you explain to us why the answer A is the correct answer?
Yes, sure. So vasopressin has the least side effect of arrhythmias because the vasopressor receptors are basically not related to the heart. They're not present in the heart. When you look at dopamine, and dopamine is actually compared to norepinephrine associated with a higher frequency of arrhythmias. And that's why probably a bunch of years ago, dopamine was not recommended anymore as a first-line agent to treat sepsis or septic shock rather. Epinephrine has alpha and beta activity, so clearly the heart is involved in the function of epinephrine, norepinephrine actually too, and levosimendan is a calcium receptor enhancer basically, and gives you more squeeze. So all of these dopamine, epinephrine, and levosimendan have an effect on the heart and thereby exert a potential of arrhythmias.
Thank you so much. We only have 5 minutes left, so I'm gonna speed us up a little bit, but I just want to let all the learners know everything can be found on the Learning Resource Center. You can go through this module yourself. You can click on the answers and find the resources that support, or click on the questions and find the resources that support the correct answer. So I'm going to speed us up a little bit. Mr. G has a MAP of 60 despite being on 40 micrograms per minute of noradrenaline. His fluid status seems euvolemic after IV fluids, and unfortunately he has greater tachypnea with a respiratory rate of 30, and his oxygen requirement has increased to 8 liters per minute by face mask. So even though we're doing everything correctly for him, he seems to be getting a little bit worse. What steps will you take to better manage Mr. G's hemodynamic status? And the answer is you would start vasopressin, okay? I made a matching game for you. So we'll go through this, but instead of asking the learners, I'm going to try to ask Dr. Vanessa Mull. So I'm going to challenge you. On the left is a clinical scenario, and on the right is the appropriate vasopressor agents to choose. So septic shock, which one is your first line agent? Vanessa.
It's number 3.
Number 3, noradrenaline. Good job. Septic shock despite noradrenaline infusion at half mic per kg per minute.
So that is vasopressin.
Yes, then you add vasopressin. Good job. I think you've done this before. Okay, septic shock, but noradrenaline is not available. Your pharmacy ran out of noradrenaline. Which one would you choose?
Then you can actually do dopamine or adrenaline.
Perfect. Good job. Septic shock despite noradrenaline and vasopressin. The patient's still septic. What would you do then?
Then you would go to epinephrine.
Epinephrine. Great. Septic shock and cardiac dysfunction.
Then we only have 5 left, so which is noradrenaline and albumin or adrenaline alone.
Awesome. Okay, everybody clap for Dr. Vanessa. Good job. Good job.
Hopefully I'm going to pass my board cert as well.
Yeah, you'll be fine. You'll do well. Okay, so with patients with a septic shock, we recommend noradrenaline as the first line agent over any of the other vasopressins. Okay, when it's not available, you can use epinephrine or dopamine. When you're on norepinephrine and you still can't reach your MAP levels, add vasopressin instead of going up and up and up on your noradrenaline. And when do you know to add the vasopressin? They suggest 0.25 to 0.5 mics per kg per minute. If you can't get your mean arterial pressure up and you're on norepinephrine and vasopressin and your volume replete, then you can add epinephrine in addition. So that's 3 pressors plus volume. Patients in septic shock, they do not want you to use terlipressin. Okay, I'll let you read more about that on your own since we're almost out of time. We have literally 2 minutes. So adults with septic shock, add dobutamine or norepinephrine or use epinephrine alone when you have cardiac dysfunction and hypoperfusion despite pressors. Okay, if you have septic shock and cardiac dysfunction with hypoperfusion, they do not want you to use levosimendan. Okay, what monitors will you use for Mr. G? Fred, what monitors would you do on him?
I think if he's in shock needing vasopressors, I definitely would prefer to have a intraarterial catheter to monitor the vasopressor therapy.
Yeah. What else?
That would be a bare minimum. I would consider a central line as well to at least administer vasopressor safely, although some people believe you can give it vasopressor through a peripheral IV. It does put the patient at risk for extravasation and a limb injury.
Yep. You're so advanced, Dr. Mean. Would you use an EKG?
Yes.
That's
That's
standard monitors as well. EKG,
okay.
Non-invasive.
You were asking about standard monitors. Yes.
Monitors.
Nice.
A bedside nurse is probably the best monitor you can have.
Absolutely.
Perfect.
A manpower is really critical. Who can be watching the patient.
That's right. Someone's got to watch the patient. What IV access is ideal? You mentioned a central line, which is perfect. I like to, even if I have a central line, have an additional peripheral line in case I need to give blood or something fast. Central line access is not available in your setting. What IV will you start and where will you place it? I thought this was a really good point in the guidelines. So we're going to go ahead and give the answer since we're out of time. We suggest using invasive arterial blood pressure over non-invasive. So that makes Dr. Main very happy. We suggest starting vasopressors peripherally to restore MAP rather than delaying initiation if central venous access is not available. When you are giving the vasopressors peripherally, as Dr. Mee mentioned, you do risk having extravasation and limb compromise because you're giving vasoconstrictors into the subcutaneous tissue. So when you start an IV, you need to start a larger size IV, preferably 18 gauge or larger, and you need to do it more proximal. So try to do it in the antecubital region or higher. So an antecubital or an EJ, something like that, that's a bigger vein is better. We are at the end. So case update. Francois, do you mind reading the case update, please?
Yes.
So,
the ICU nurse calls you because Mr. Jen had emesis with a large volume of bilious liquid. He is now short of breath and requiring 15 liters per minute by non-breather mask. She also said the laboratory called to report additional investigations data. You asked for a repeat chest X-ray to be performed immediately at the bedside. You arrived in the ICU to find Mr. G on 15 liters per minute, oxygen by mask, but short of breath, ill appearing, and with increased work of breathing. Noradrenaline is infusing at 0.5 mics per kg per minute, and vasopressin is infusing at 0.03 units per minute.
Thank you so much. That concludes this session. Again, everything's available on the Learning Resource Center if you want to review anything we talked about today or read the articles that support our answers. Also,
Anna?
remember there are facilitator slides that you can download if you would like to teach this course to others.
Anna, can I make a comment?
100%, yes, please do.
There was something made quite a bit earlier, and I didn't know where to jump in to say it, but somebody was confused about when we were talking about crystalloid solutions and balanced solutions, and we mentioned the word plasmalite, and somebody commented that we're concerned about whether we were talking about fresh frozen plasma or giving actual blood product to a patient. We weren't talking about plasma, fresh frozen plasma. Plasmalite is just a brand name given to
that was Edwin. I think Edwin made that comment. I think he was referring to that instead of albumin,
yes,
which may be more available. I think FFP in general is much more expensive and a more precious resource. But what are your thoughts?
Yeah, I agree. But I was concerned that perhaps was our use of the word plasmalite was confusing somebody.
No, I think Edwin knows the difference. I think he was just saying what resource he was using in his setting. Yeah, I think he knows that. Thanks.
I retract my comment.
We always appreciate everyone's comments because it adds to the discussion and learning. I like to always end on a quote. If you're not willing to learn, no one can help you. But if you're determined to learn, no one can stop you. Thank you to all of my amazing panelists. You guys are so wonderful. I'm so lucky to have you in my life and as colleagues. So I'm really grateful to all of you. And I think the learners were just outstanding today. Really great participation, really great comments in the chat box. And once again, really need to just give a huge shout out to Alana, who makes everything possible. She makes our presentations beautiful. She brings us all together, and I'm just incredibly grateful for Alana every single day. So thank you to all, and we'll see you on Friday. Friday, we're going to talk about lots of other things, including steroids. Somebody asked about steroids, so. The recording will be placed on the Learning Resource Center. We encourage you all to sign up on the Learning Resource Center. It's free, and then you can have everything. We put everything in one place so you can access it all there. And I'll put that in, we put it in a few times, so I'll put it in the chat box once again. Oh, and look, Alana is so great, she beat me to it.
Great, thank you everyone for joining, and we will end the session momentarily. And as Anna said, the recording will be posted on the Learning Resource Center either today or tomorrow. Goodbye.
Goodbye, thank you.
Thank you, everyone.
Bye, thank you.
Thanks so much.